Talk about one of the most common fracture in the orthopedic day-to-day practice. That is the fracture distal radius. Now, you're supposed to know a little bit of the anatomy of the distal radius also. Why it is so much common? It is one of the insufficiency fracture. There are three fractures being considered insufficiency. One of these is this. One is spine, one is the ventricles. So what is the peculiarity of this part of the bone? Mostly you will find this injury metaphyseal. And this part is mostly cancellous. 1 point. And person who is having a good reflexes, they used to have this sort of fractures. What is the meaning? Person who is going to fall. So reflexively what is do? He used to protect his vital structures, that will organ, by sacrificing his hand. So that is why outstress hand is more common those whose reflexes are indirectly. Otherwise those person who is not having this reflex going to fall and cause the fracture of the neck or trochanter. So it is one of the protective fractures in our body. Protective fracture, because you try to save the other structures at the cost of this. Like the patellar fracture is a protective fracture. So it is your sacrificing itself to preserve the femur condyle. What is the anatomy here? Normally this articular, see, this is triangular in almost shape or section. Styler process. What is this? Notch. This notch is very important. Earlier days this notch was not very important was given, but nowadays it is one of the most important structure which is very much important for particular rotation. And in a situation where there is involvement of the grooves, the prognosis is bad. It is coming out in studies that the involvement with grooves results are not good in those cases where there is no involvement. So involvement of the grooves is very important in the final outcome of the fracture. There are two processes. One is styler process. This is Lister's process. These are anatomical landmarks are very important for us. Styler process, Lister's tubercle, and this is notch. And the articular surface do have two processes. One, you know, this is first scaphoid, and this is lunate. What is the importance of lunate fracture? Dipens fracture. Dipens fracture mostly find only vertical fracture. Normally what happens, while the patient is falling, they make an angle like this. And this angulation leads to what? Two things. One is stressing of the anterior surface, one is compacting anterior posterior surface. So most of the time you will find what? Combination of the dorsal. Are you getting my point? So mode of injury in case of your Cori's fracture is mostly outstress hand. This is a reflex mechanism most of the time. A person is falling to save his own important structures, and many times they are falling with an angle. And this angulation fall lead to what? One is stressing, another is compacting. Stressing in anterior surface, it is most of the time a Wilson type of fracture. Stress. Only under dorsal surface is compacted. And since it is osteoporotic most of the time, you will find the dorsal fracture is comminuted. If you take the X-ray, you find the anterior surface one fracture line, dorsally there is comminution of fracture because falling like this. Right? So on the other hand, if the fall is more vertical, then what is the impact of the force is going vertically, and it is the Dipens fracture which is very important because it is interarticular fracture. Interarticular. So you do not unable to maintain the congruity of the articular surface, probably result will be not good. So Dipens fracture is very important. Many times it is not very easy to diagnose. The step in the articular surface gives you the hints and may confirm with the CT scan to see what are the integrity. Because diaphragm fracture is sometimes without involving the anterior posterior cortex. Sometimes it is a depressed type of fracture. Type 3, Saskar. That is. So that is one of the important things you are supposed to know. As such, in distal radius fracture, what are the fractures? One is the most common fracture which has been described by Abraham Collins in 1881, 1814, long back, before invention of the X-ray. He has described everything at a time without X-ray, and also said that even there is little bit of angulation or malunion, a person can able to do almost normal activities with deformity. So major major work he can do with little bit of angulation also. This is being stated long back by Abraham Collins 1814. Subsequently, of course, many things are coming up. Nowadays we talk in context with what? Columns. In context with columns. As such, in a fracture distal, what are the fracture? Common fracture is your Colles fracture. That means falling like this. What is reverse Colles? So in Colles fracture you never get anterior displacement disadvantage. So impact of the force is like this. Yes or no? So there is no question of the fragment and distal fragment coming anteriorly, because impact is coming like this. So it is always going posteriorly. Yes? If the reverse things is happening there, it will be falling like this in these situations anterior, which is very uncommon, very rare. Almost out of 100 cases, probably 1 or 2% of cases will be get anterior. So this is reverse Colles or fracture. 1. Number 2. Number 3, bottom fracture. There are two types of bottom fracture. The mechanism is almost same, which is invariably in the interarticular fracture. Where what happens in bottom fracture?
It's a rim is fracture.
What? The fracture along with dislocation of what? Radiocarpal. Two things. One is interarticular fracture. Integrity of the ligament is very important. So mechanism of reduction technique and treatment protocol depends upon the integrity of the ligaments. That is why our concept in the treatment of conservative treatment in the head should to be clear. Are you getting my point? So in the supposing there is anterior fracture, if you do conservative treatment, how will you keep the limb? How will you keep the limb? Anterior. So like this. Yes or no?
Yes.
No. This?
Yes.
Or this?
Sir, nowadays
that is important. Nowadays, actually, previously we didn't understand. Because it is fact. This is your evulsive type of fracture. So, your ligaments are very important, integrity. So, on the basis of this integrity of the anterior ligament, you have to do this. So, in the anterior bottom, you do this, dorsal bottom like this, not the other way. This is one. So, anterior bottom fracture, posterior bottom fracture. Another fracture is a Sophers fracture, which is involved in the styler process. Sophers is coming from what? Driver. They used to study, so it's backfiring of this to your Sophers fracture, which is uncommon, very rarely seen. So, by and large, then what are the fractures? Colles fracture, reverse Colles fractures. Then your bottom fracture, anterior bottom, posterior bottom, which is more common anterior, Sophers fractures, and nowadays of course you can use diaphragm fracture. Now in the Colles fracture, this is most common, so let us talk about this. In the anatomy also, let us talk a little bit of anatomy. Nowadays we talk in the context of what?
Columns.
So what are the columns?
3 columns.
3 columns are here. What are 3 columns?
Sir,
What are 3 columns?
sir, lateral column, middle column, and medial column.
One is lateral, another is middle, another is your
Medial
column. So what is lateral?
So through the scapula.
This is medial. And if the scaphoid line,
In this it's a letter.
The lateral. Or the lunate line,
Middle.
which is more important?
It's a middle.
So out of this major column is integrity of the major column is involvement, where do you get the diverse mixer and also involvement with juice. So these are the three columns. Nowadays people are coming with the concept of columns. Now this is one. Now in the anatomy again we need to know something more details, because this scene that if you are unable to, okay, the statement of your Abraham Collis was true, but he said cross movement, but finer movement probably is interfere if you are unable to maintain anatomy. That is important. So that is why we must try to bring back the pre-trauma anatomy. To bring the pre-trauma anatomy, so we must know the normal anatomy also. These columns are there. Otherwise, you are more concerned about the what? Articular integrity of this area and its alignments. So what are things we are supposed to know? One is called what? So normally the articular surface of the distal ulna, distal radius is downwards, forward and medially. That is crossly. Crossly, downward, forward, anterior and medially. So this is the cross. That is for undergraduate. But for postgraduate you are supposed to know the angles. So normally that means articular surface is facing anterior, grossly, and it is also facing underward. So it is grossly facing anteriorly and underward, downwards, forward and medially, downwards, forwards and medially, grossly. Downwards, forwards and medially is the cross, but you have to define. So these angles are important. Now what are the angles and how to calculate it?
So radial inclination.
Radial inclination. What is radial inclination?
Sir, so the angle between the perpendicular to the line through the radial shaft and the angle formed by a line joining the radial styloids.
Yes, sir. There are few things you are supposed to know. One is
distal on the articular surface of ulna से perpendicular line उसके बाद radial styloid के बीच का height.
first thing common things you tell me. What is anterior angulation? Means your palmar.
So 8 to 12 degrees.
One is radial tip. One is palmar tip. What is palmar tip?
Sir, average 11 degree and range is 8 to 12 degrees. Sir.
This is palmar tip. Facing anterior. Palmar works. So normally if it is a perpendicular one, then angle is like this. This is perpendicular. But I said then the face articular surface facing anterior. This from this to this is around
11 degree.
11. Variable is there. Sometimes after 11. Average. One point. This is your palmar tip. Another is your
Sir,
what is this?
Sir, we will draw a line along the shaft and we will draw a perpendicular to it, and another line we will draw from the radial styloid and the lowermost articular surface of the.
Correct. That means your this angle. So normally this is perpendicular line, and if it is like this, as I said, so this is your
23 degree.
that is 2. Number 3,
So, radial height, sir. Radial height.
radial line. What is this? This is a normal radial. So what is that? Styloid process. The difference between two styloid processes. That is normally that is also important for the clinical practice. After reduction, if you do not have this facility of X-ray there or the CM there, how clinically can tell us that I could able to make the reduction possible? This is going to tell you that my radial styloid process should come down below that of the ulnar styloid process. It is important. So that is the normal relationship, and our maneuver should try to bring it back to the normal previous relationship. So clinically one can do it. Clinically. So we can do nowadays with CM and beta reduction, so that is different thing. Otherwise, clinically to know this, that this size is supposed to go down below than half inch almost. Anything more than that?
Ulnar variance.
What is ulnar variance?
So difference between the articular surface of the
Yes.
ulnar and radius.
Ulnar variance and this difference is not same. So styler process relationship is not same with that of your ulnar variance. It's related to articular surface. So this, so normally, no, so okay. Now what is the relationship?
So normally it is
What
not
negative means?
negative, sir. -1 or minus variance.
Negative means what?
So it is below, sir. Proximal. Ulnar articular surface is proximally located, sir.
It's supposed to be proximal and she is supposed to be distal.
Yes.
Accepted. And now what is the occupancy here? Or what is structure here in this area where there it is like this? Then there is something there. This is TFCC. So TFCC is occupying this. Another important structure which is not very much your not very much discussed, but plays a very important role in the final outcome of the distal radius fracture is TFCC. One is interarticular involvement. There are two things are important here. One is your radiocarpal involvement, interarticular. Under interarticular is your bruise involvement. Okay? Another is your TFCC. Study says those person who undergo repair of this TFCC do good in long term rather than those who are going for conservative treatment. So TFCC repair is also important for long term outcome. So that is actually radiologically not seen, but it is important structures which plays a very important role in final outcome of the injury. So these are important things. Another important thing is your, anybody knows about teardrop?
Yes.
Teardrop angle, what is that?
From the shaft will draw a line, and from the around the
But it is APV or lateral view? Lateral view. It is a lateral view. It is, how do we do it or acceptance of it? No? So you make a round.
round the AP distance, the circle must fit the
Fix it. Circle of what? Articular surface of the lunate, basically. And your anterior fragment which is going anterior, they makes an angle with the long axis of the radius. Normally, what is the angle?
45 degrees.
With 70. Correct, is right. 70. But this variability also plays important role. These are new things are coming out. Anyway, these are the calculations. We do the in the X-ray also. So anatomically different important things you are supposed to understand. And this plays a very important role. Besides the ligaments are also there. One of the important muscles that plays a very important role in outcome is
APL.
brachioradius. What is the insertion of brachioradius? It is here. So it is in this radius. So sometimes you will find a avulsion fracture coming out lateral valve. This is brachioradius. This is interestingly attached here, not going down clear. Other ligaments, tendons which are coming out, going, extending distal to the joint and then the gear attachment. Brachioradius is attached here. So it causes some avulsion fracture. Nowadays, it is a fragment specific implants are nowadays coming up. So to address all these things and try to bring back the anatomy before also. So to have this paper, so what next thing it's supposed to do? X-ray of the opposite side. The ulnar variance which is taking out the positive or negative maybe have some sort of anatomical variations in the person. So to know there how much I supposed to do, I supposed to have a X-ray of the opposite side. That will give you the guideline that this is the thing which I supposed to achieve. So in a situations where you are dedicated to bring back everything normal, then you take the help of the opposite side X-ray. That will tell us what is the level, how much I supposed to achieve. So normal your ulnar variance has got positive, negative, or neutral, whatever it might be, variability, and in normal person also these things may be there. So as I have to have a guideline, I supposed to have the opposite side X-ray to tell us how much I supposed to do. Now this is anatomy. Basically these things are very important. Besides the other important ligament just plays very important role. Very important role. But the things are important that when outcome, the intra-articular involvement, particularly radiocarpal, bruise, diapons flexor. Yes? So these are very important things. Final outcome. Besides, if there is only your flexor there without involvement of the intra-articular involvement, the results are better. So that is why critical analysis should be important we have to do, so that I can able to bring the anatomy here. Now what are there are certain classification now. All of discussion in case of your Colles flexor, what are the displacement?
Dorsal tilt.
By the way, what is the definition of Colles flexor? Definition of Colles flexor.
So it is a fracture of the distal end of the radius involving the corticocancellous junction with or without distal radius ulnar joint involvement.
And
In SQ2.
without involvement in TFCC. And
Or ulnar
so it is basically mesoid portion. So normally before skeletal maturity you get epiphyseal separations. Colles flexor is seen up in adult. So the definition is within 1.5 inch. 1.5 centimeter more than 1 inch. Roughly earlier days we used within 1 inch of the region. Now to remember 1 inch. 1 inch of the region. So within 1 inch of the region, with or without flexor to the ulnar stellar process, with or without injury to triradiate cartilage. Earlier days triradiate cartilage. Nowadays TFCC. With or without ulnar collateral ligament injury. In and at all. Now what are the displacement?
Dorsal tilt, dorsal shift.
There are 6. One is dorsal displacement, dorsal tilt. Now what is the difference between a tilt and a displacement? What is a tilt? What is a displacement? Tilt is angulation. A person is here, so if you are tilting like the angulation, the fragment is angulating but keeping in the base. That is your angulation, the tilt. When my flexor is there, I am going like this, so this is tilt, angulation. But if the base is being shifted, that is displacement. So two things here. So suppose these are two things. One which is going like this, tilting towards the angle. Another is shifting here. This is displacement. So this is what difference. One is displacement, another is tilt. Displacement is defined as the what? Definition? Distal to the flexor. The relative positions of the distal fragment to the fragment distal to the flexor in relation to the proximal fragment. Considering the proximal fragment is normal. That is called the definition. Definition is relative positions of the distal fragment in relation to the proximal fragment. Considering the proximal fragment is the anatomical one. So that is called displacement. Angulation is the angle. When tilt is angulation, when the base is still here. When the base is still here, but there is angulation. Contact is there, angulation is there. If the fragment is moving away, that is your displacement. So the definition should be clear. Okay, sir? So there are 6 things happens. One thing is never happens here, anterior displacement, because third is coming anteriorly. So displacement means impact of the force is going posteriorly. There is no question it is coming anteriorly. So it is reverse correlation depending, otherwise here is not possible. So if you fall in like this, there is a fall and there is angulation. This is your dorsal tilt. Fall and fragment is going like this dorsal displacement. Okay, sir? One. Number 2, lateral. The fragment may go lateral. This fragment may go lateral displacement or sometimes may lateral tilt. Another upward. It may go in sometimes it is a short. The fragment is going into. So this is upward displacement and sometimes rotation. supination external rotation. But what is not possible is medial displacement. Medial displacement. If ulna is here, this not allow you to go to medial. So medial displacement no, anterior displacement no possible. Only is when dorsal displacement, dorsal till, lateral displacement, lateral till, supination or upper displacement, this flexion. ठीक है sir? So this is one. So in the X-ray, what are the X-ray you suggest? AP view and lateral view and facet view. One is a facet view, another is your oblique view. So in a case which is coming on outstretched hand, may have flexures in other part also. Sometimes even scaphoid flexures may be there, particularly in young patient. You instead of having the flexure of the police flexure they may have. But these flexures are mostly seen in two bimodal. Earlier in the, around 10 years, one children used mine, though it is not said the police flexure, under age around 60 to 70 years. These are the common group of people where you get increased number of them. In the middle group may not have a police flexure, sometimes scaphoid flexure will be there. So that is why you suggest the except for AP, lateral and oblique view. And what is a facet view? Why do you need to do a facet view? Facet view is the same thing that of your, you do the facet view from the tibia. You know in tibia there is the inclination. 90 degree. Not 90 degree, but there is almost 5 to 10 degree stop is there. So to know the articular surface integrity, then you do tilting of this beam so as to go parallel to D. Same thing is applicable here. Because you know the anteriority is like this, so you do the inclination to the articular surface. Same. Okay, sir? So that is why it is. So these are the variability. Otherwise, in normal situation, you go for AP, lateral, and oblique view. Oblique view is mostly to know the scaphoid, actually. Mostly for the scaphoid. AP, lateral, and oblique view. In the AP view, what are things you see? So this, as we discussed here, as already discussed now, now tell us what is finding here. This is Acha, how do you read the X-ray?
Inside out or outside inside?
How do you read the X-ray? Tell me, I can ask you. How do you read the X-ray? When I read it, is it like this or what? This is right. This is what? Right side. If it is right side, is it okay to place it like this? How to do? Tell me how to do. Okay, this is the wrong thing he is doing. So, why you are doing so? So this is the wrong thing he is doing. So you read the X-ray as if the patient is facing to you anatomical position.
Yes.
So you read the
Yes.
always try to read the X-ray in another as if he is facing to you. So place it like this. This is correct or wrong? Correct. Why it is correct? Oh, it is to be another position. Radius is always lateral, ulna is medial. One thing, wrist is always down, elbow is always up. So the basic principle you are supposed to follow in reading the X-ray is that I am supposed to read as if the patient is facing me in another position. This is one. So to place the X-ray like this. So minimum two views are necessary. One is APN, another is lateral view. Lateral view incorporating the proximal and distal joint. This is important because one condition is a type or why it is important?
SS closer to
Is right. So here also you will find this distal and proximal junction involved. So it is always mandatory to look for the X-ray as a whole involving both proximal and distal. It is important and try make it a habit of doing so. So do not accept the half-done X-ray. So sometimes you may miss important stuff. Even sometimes radial head fracture, the impact of the force is like this. Fracture is there, but equally there may be injury to radial head. So that is why it is important to be quoted. This is must. One point. Now this is AP view. Why the AP view? We will be interested specifically. Then another lateral view. Sometimes you may get a space, sometimes no. But pure lateral view should be pure lateral view. How do you know which part is anterior, which is posterior in this X-ray? Because hook of the helmet. In the pure AP view, you will find pisiform is lying most anteriorly to the studio of the pisiform. Hook of the helmet always anterior. So that will make you understand whether the anterior posterior. So if you do this X-ray here, what is findings here? In the X-ray, the ulnar styloid force. So you have to tell us in AP view, this is lateral view, encompassing the elbow and the distal and the distal part of the humeral, the wrist and also the metacarpal bones in AP view. Then you use the elastic radius and then this alignment. So always in the X-ray in the line of A, B, C, D. A stand for alignment. B stand for bone. C stand for your ligaments or soft tissue. Sometimes cervical spine cases, disc, and in other cases also soft tissue. Okay, sir? These are the basic things so that you do not miss it. And once you read the X-ray systematically from one into another. So in this situation, one of the things where there is a fracture in seam, which is almost vertically long axis. Long axis. Another fracture is there. Now, if it is fracture like this, now what classification will follow to express? Frequent. So, what is the basis of the frequent classification?
Sir, involvement of the radiocarpal joint.
Three things. One,
Involvement of radiocarpal joint.
interarticular. Interarticular, either radiocarpal
Or radial.
or radiocarpal. Is it? And another is your involvement in the ulnar styloid. He is considering these two points mostly. What he is not considering is the displacement of the fragment. So that is why practicality of this series, the outcome is not very acceptable in the sense that he is not discussing about the displacement of the fragment. That is very important. He is saying on the basis of the involvement of the grooves in the interarticular fracture. So how many grooves are there? 6. 8 or 6? 8. 8 on the basis of what?
Extraarticular with ulnar styloid.
With or without ulnar styloid. Again.
Intraarticular involving the radiocarpal joint with or without ulnar styloid.
Again.
Intraarticular involving the radio.
And last one is intraarticular. Both. Last one. Both. One is this. One is this. Another is both together with or without ulnar styloid. These are the 8. Okay? At least one classification is supposed to know. There are so many classifications coming up. Nowadays, of course, for research purpose or better comparativity and prevention of inter-observer variability, people are using Euro classification. This is 2, 3. Again, ABC. 2, 3 means
Radius
because it is still 2, 3. Are the 2, 3. 2, 3. A, B, C. Same. They are also considering this thing. Nowadays it is said that intra-observer variability is a bit less if you follow this. And is also important for research purpose. So that is on 2, 3, A, B, C. A extraarticular, B partial, C connected to D particular. So this principle is remaining same with that of the other fractures classification, and this is important nowadays being considered practicality also. So to avoid inter-observer variability. So that is important. So for research purpose, thesis purpose, research for you do, and comparative study particularly. This classification is right. Otherwise, other classification, another Fernandez classification
Fernandez,
is
Mellon.
and Mellon classification is there. So many classifications there. Yes, another classification. So things are there. But these are the classification. Nowadays, people are shifting towards the Evo classification 2, 3, A, B, C. Okay, sir? Now tell me, is it police flexor or something else? Why it is not? Bhola bottom flexor.
No.
But you said it is a flexor, it is Bhola bottom flexor or something else? It is going like this. Now, articular surface is there. Segment is going to intuitively. If it is going intuitively, then what is it flexor? Smith flexor. Sometimes Smith flexors, there are three types of Evo flexors. Antepartum flexor sometimes confuses with the Smith type 3. The Smith has also three sub-classifications. Principally, it is anterior shift. Type 3 is also same with that of your antepartum flexor. So there is some kind of confusion in there. But in your Smith flexor, interarticular involvement is not same. So the payment is going anterior. But in case of your bottom flexor, it is always interarticular. So anterior payment is going to. Okay, sir? So this is one. But okay, this is how you have to study and you will do the treatment. As such, how do you treat a Smith flexor?
So, close the
Police
question.
flexor, no.
Same as police structure, like normal structure with the deviation.
No.
Deviation will not deviation.
No, you are wrong. Anybody who knows how to apply Smith cast? Smith cast patient should be in superimposition.
Yes.
And almost always, you go to Sunday, it is above elbow cast. Above
Neutral.
elbow cast. Because your deforming forces are more here. So it is always, correction is there, supination and above elbow cast. In case of Smith flexor. This is, not this. Okay, sir? Police flexor, okay, you can do it. You know how to extend it, but reverse police, Smith flexor is above elbow and it should be supine. You did Charlie, that's mentioned. So this is one. Yes, sir? So now police flexor. It is minor. So on push to acha हाँ. This is one.
This is Bora button, sir.
This is one.
Bora buttons.
देखो. So as मैंने okay fine. First, मैंने are you happy with placing the X-ray?
No, sir.
No, sir. Always while we are getting in the X-ray,
Remove the angles.
you keep in proper position. Keep in proper position.
Yes, yes. One is correct, one is wrong, sir. Sir, printing is wrong, sir. ठीक है Moni.
My third year PG, you are still confusing. Now only I have said about the principle of placing the X-ray. Why you are so much confused? My dear, it is R. If it is R, radius is always lateral. Then how you? This is principle. Are sir, you should not confuse by this term. These basic principles are mentioned. While uttering any word, you always mention whether it is skeletally measured or unmeasured. There are few things common. Basic principles remain same. Keep it in anatomical position as it is facing you. Right, sir? No confusion, nothing. Then you tell us the geography, how much you are seeing in the X-ray. And what are the views? Then again go for ABC. Yes, sir? This principle. And while starting your opinion, always talk about whether it is skeletal measured or unmeasured. Female, male, it is not very important. But it matters. The skeletal measured and unmeasured, it matters. So, from the X-ray, one thing, at least one can be, sir, this is skeletal measured person, unmeasured person. Then you talk on the pathology, what is their saying. As of now, the grossly you are seeing what? What thing you are seeing? This is your interdimensional flexion. There is displacement of the what? Radial. It is important. So this whole segment is going along the flexion. It is important. So it is an interdimensional. Invariably it is should be treated by what? What is the principle of treatment?
Buttress plating.
Entry. So proper reduction. Anatomical reduction is a idea. Two rigid fixation and articulation. This is the principle of your principle of interarticular fixation. This is the interarticular fixation. So it is supposed to be treated by. But those persons who refuse to get property or is not fit, then how you are going to apply the plaster? You will go for the form of flexion. Full and function, not the dorsal flexion. So in Watson it is mentioned currently, but basic principle is what makes the integrity of the ligaments here. Integrity of the ligaments here. In this alignment with that of your carpal bones. This is going to play a very important. That is why this unit to go to the alignment. This consider this unit, okay, then bring this fragment to this alignment. So here you have to do forward flexion. Non-dorsal flexion, forward flexion. In dorsal your bottom flexion, you will do the dorsal flexion. So this is clear. So those person who refuses to go for operation, at the most one can do this. Otherwise, interarticular flexor, either treatment is for proper treatment, do rigid fixation, and give articulation. This is principle. But both person is not fit, refuse to see option. Yes, sir? Next. This is the common thing. Okay, sir. You can have. This. Now put the X-ray and read the X-ray. What you are confusing again? What is some called? Basic principle. Descent is facing you.
Yes.
Descent is facing you.
ठीक है.
And we have to place the X-ray in the center.
जानबूझ के करते हैं.
It belongs to what? Right side. Area is supposed to be what? Lateral. The place is lateral. Now why you are confusing again? I am asking you to be stable and adhere to the basic principle. So I told you that you did the X-ray as if he is pressing to you in anatomical position. This is how you are going to do this. What is the finding here? What is the finding here? What is the flexor? What? What is flexor? So, read out the X-ray. What is more important to understand now? You calculate the joint. When a grossly distal fragment is being 1. Number 2, what is the relationship with standard process? Is it okay? No. Not okay. This might be there. It means upward diagonal. And what about the attitude? The fragment is being laterally or ventrally? Laterally. So at least from the X-ray in the lateral view, dorsal displacement is there. In AP view, lateral displacement is there. Now what about the angulation? Are you happy?
Neutral.
So immediately articular surface of the distal radius. How it is facing? It is supposed to face anterior, palm outwards. You palm outwards. Is it facing palm outwards? No. That means what? Tilting why? Push your displacement and push your tip. lateral displacement. Yes, sir. So you have to calculate it. And if the pavement is more horizontal, suppose if this is more horizontal, it means what? Lateral. Lateral. It is more horizontal because you are supposed to give angulation towards the other side. And if it is more becoming horizontal means it is lateral. So in the X-ray is a police flex of the adult. Involvement, yes or no? Police flex always happens in the adult. If it is depending in the children, it must be police flex. So in this situation, this is posterior displacement, posterior tilt. Tilt because the pavement is almost permanent. You are supposed to have it on lateral displacement and lateral tilt. And there is also repeated the upward displacement. Why? Because the understanding process, and acceleration is up. So you have a mindset now. You have a mindset that how am I going to treat the patient? You have to treat this material in your mind. Then while doing corrections, you have to correct it. Now while giving the traction and counter traction, what are things can be corrected here? One is this being inflicted, that means upward migration to be corrected. One point. But to some extent this angulation will be corrected if it is placed. Otherwise, you have to correct this posterior displacement, posterior tilt, and lateral displacement, lateral tilt. So you have to correct. Then where I supposed to apply the force to correct this deformity? So this X-ray critical analysis is important for what? Important for what? That what I supposed to do during manipulation to overcome this your deformity. After all, we want to bring the distal fragment to the alignment of the projectile and try to maintain the normal anatomy. Yes, sir. That is why these things are important. If it is fragment is going to dorsally, posteriorly, then I supposed to push the force from dorsal side entries. And if it is lateral displacement, I supposed to push it from lateral. Yes, sir. So it will be. Then you do the calculation from clinical side. What is the relationship coming out after manipulation between the two stylo processes? They will tell you that whether upward migration is correct or not. So these things are important. So that is why all the access should be analyzed before going for the manipulation, and also clinically judge that whether I could put the CB or not. X-ray is always there, CM is always there to go for, but clinically supposed to do it first and confirm with the X-ray so that you develop the clinical acumen to correct it without having the X-ray. Confirm with the X-ray, but do the manipulation yourself with the judgment. Then I have critically analyzed the X-ray. I have found my fragment is going dorsally and dorsal tilt towards the dorsal side. One point. Another point is lateral displacement, lateral tilt. Supination and upward migration, upward displacement is corrected most of the time by the traction and counter traction. This inflection of the fragment. After doing this inflection, you correct the deformity and the. This principle should be met. Okay, sir? So next time, read the X-ray. Carefully, do not get confused. X-ray you study as it is facing to me and so then study and do this.